Well, let me officially welcome everyone to the first webinar in the 2021 Virtual Chordoma Community Conference series. I'm Shannon Lozinsky, Director of Patient Services at the Chordoma Foundation. I will be moderating today's webinar and the rest of the webinars in the conference series this year. We were very disappointed not to be able to host an in-person community conference again this year due to the pandemic. But we're very glad to be able to bring you this series of webinars in place of that in-person event. And today we'll be talking about managing pain. We know, of course, that pain is something that the vast majority of chordoma patients deal with at some point during their journeys with chordoma. There are some specific types of pain chordoma patients and survivors most often experience. There are also a number of ways to help manage that pain. Unfortunately, there can sometimes be challenges when it comes to finding an effective and comprehensive pain management plan. Our goal for the webinar today is to help you learn more about pain management options, and about how to access those. And so with that, I'd like to welcome and introduce our speakers. We are fortunate to have 3 speakers with us today who are experts in various methods of managing pain. Dr. Maryam Jowza is an assistant professor of anesthesiology at the University of North Carolina and is part of the UNC Health System, where she specializes in pain management. Cancer-related pain, post-surgical pain, and neuropathic pain are a few of the things she focuses on in her practice, so she'll be talking with us about those today. Dr. Sasha Knowlton is an instructor and the Assistant Director of Cancer Rehabilitation in the Department of Physical Medicine and Rehabilitation at Harvard Medical School. She practices as a physiatrist at Spaulding Rehabilitation Hospital, which is part of Massachusetts General Hospital. She is also part of the team at the Harris Center for Chordoma Care at Mass General, which many of you will be familiar with. And she is also a member of the Chordoma Foundation's Patient Services Committee, which helps guide the strategy and direction of our patient services programs. Dr. Knowlton will be talking with us about how rehabilitation, such as physical and occupational therapy, can help relieve pain. And Dr. Staci Martin-Peron is a psychologist in the Health Psychology and Neurobehavioral Research Program at the National Cancer Institute's Center for Cancer Research. She specializes in using acceptance and mindfulness-based interventions for coping with the physical and psychological. We are so happy to have all 3 of you with us, and Dr. Jowza, you will be leading us off, so I'll turn it over to you.
Well, thank you, Shannon, for that lovely introduction. I'm going to share my screen here. All right, well, thank you for having me. It's great to be here. I'm going to take the next 10 or 15 minutes to talk to you about pain management options in patients with chordoma. I was actually seeing a patient the other day, and I was seeing him for nerve pain. He has neuropathy in the feet, and we were discussing about treatment options. At the end of the visit, he said, "You know, doc, I also have arthritis in my knees that's been acting up. Maybe this new medicine that we're just talked about and are going to start is going to help me with that too, right? Because pain is pain, right?" And I thought to myself, well, yes, but no. Broadly, there are 2 different types of pain. There's nociceptive pain and there's neuropathic pain. Most pain is nociceptive pain. It comes from stimulation of pain receptors from tissue injury. Most of us feel some sort of nociceptive pain throughout the day. This is what you feel when you stub your toe, get stung by a bee, or cut yourself shaving. This is the pain that comes from tissue damage. And even though it hurts, it's also protective. It tells you to stop doing that thing that you were doing that caused the pain. Nociceptive pain is typically, it's aching, it's sharp, it's throbbing. If it comes from the skin, the bones, or the muscles, it's easy to tell where it's coming from and how to localize it. If it's coming from the internal organs, like, for example, the intestines, as would happen with something like an intestinal blockage, it can cause a deep cramping pain, and it could be hard to pinpoint. This type of pain will usually get better as the injury resolves and is treated differently than something like neuropathic pain. Neuropathic pain occurs as a result of damage or injury to nerves. It's felt as burning, tingling, sometimes electric pain. The area may be sensitive to touch. Oftentimes, the pain doesn't improve even though the initial injury resolves. Clinically, in chronic pain, most pain is a combination of nociceptive and neuropathic. And there are some questions that your doctors will ask you to get a sense of which kind of pain you're having to help better guide treatment. So your doctor will want to know where the pain is. Is it the neck? Is it the mid back? Is it the low back? Is it the abdomen? Your doctor will want to know, what does it feel like? Is it sharp, stabbing? Is it electric? Is it burning in sensation? Does it go or radiate anywhere? And how severe is it? This is where the 0 to 10 pain scale is often used. Other questions are, what makes it better and what makes it worse? Because that can also help guide treatment and take you down a path that maybe your doctor would not have thought about otherwise. So when we're talking about treatment, we have to keep in mind that chronic pain is really a multidimensional process, and it involves many overlapping parts. The best outcomes are with a multi-pronged treatment strategy. These include more than just medications and procedures or injections. Therapies, both physical and behavioral, are an important part of treatment, as is complementary medicine and family support. Generally, when some of these components are neglected, effective pain management can be compromised. I was asked to focus my talk on medications with an emphasis on neuropathic medications to help with chronic pain, as neuropathic pain is what's frequently found in chordoma. My other colleagues will speak about some of the other components of treatment. The thing that I want to stress, and I say this to my patients frequently, is that if the strategy or the expectation is to have one pill or one medication solve everything, then we're setting ourselves up for failure. So just as the treatment for chronic pain is multidisciplinary and involves other specialists, the pharmacologic treatment can involve several agents. Another way to say this is that basically to use everything that we have to help the patient feel better. When it comes to medication, though, this is deliberate, strategic polypharmacy. That's what it can seem like, because it's multiple agents that are being used. I'm going to take you through some of the more commonly classes of medications that we use for chronic neuropathic pain, and none of them will have an indication specific to chordoma. Clinically, when a class of medicines shows effectiveness for one type of nerve pain condition, it is very frequently used and often effective for other nerve pain conditions. So what does this group of neuropathic medicines include? One of the most commonly used medicine for chronic pain is actually a medicine called Gabapentin or Neurontin. This is FDA approved for pain related to shingles and seizure disorders, but its off-label use is very, very common, and probably more common than what it is approved for. It's very frequently used for peripheral neuropathy, for neuropathic pain when we just don't know what the cause of it is. We also use it frequently for widespread musculoskeletal pains, and frequently for pain related around the time of surgery. So sometimes it started before a planned surgical procedure and continued for a period of time afterwards. Gabapentin has a cousin medicine called Pregabalin. This is FDA approved for diabetic peripheral neuropathy. So this is neuropathy usually in the hands and feet for people who have diabetes. Post-herpetic neuralgia, which is pain related to shingles. Fibromyalgia, which is a diffuse musculoskeletal pain condition. And also neuropathic pain related to injury of the spinal cord. So again, even though it's approved for these indications, it is used for many other types of neuropathic pains as well. The side effect profile for gabapentin and Lyrica is very similar and actually quite favorable. One of the more common things that people can experience are drowsiness, confusion, unsteadiness when walking, and swelling in the hands and feet. But overall, when started slowly and dose titrated up slowly, the medications are pretty well tolerated and have become one of the first line medicines for neuropathic pain. Certain classes of antidepressants are also used for neuropathic pain. These work by enhancing the body's own anti-pain signaling. The improvements in pain with these medicines are not necessarily related to improvements in mood. So some patients shy away from this class of medicines because of fear or stigma that's associated with mood disorders. But these medicines can be very effective for nerve-associated pain, and oftentimes are more effective when combined with other classes of nerve pain medicines. Examples of antidepressants that are used for pain are the tricyclic antidepressants. These are older medicines, and examples include amitriptyline and nortriptyline. Another newer class is the serotonin norepinephrine reuptake inhibitors, also known as SNRIs, and some common agents in this class include duloxetine and venlafaxine. Common side effects with these medicines are nausea, dry mouth, and changes in sleep, and sometimes this may be a good thing, and we can time the time that the medication is taken to help take advantage of perhaps the sedating side effects so it can help with sleep. And we know that improvements in sleep can be very helpful for improvements in pain. In people who are older, we do worry about something called orthostatic hypotension, which is a drop in blood pressure when going from sitting or laying down to standing. This can cause dizziness and in severe cases, falls. So we want to be very careful with this. We also want to be careful about interactions with other medicines. Muscle relaxants can also be used for chronic nerve pain. Sometimes, depending on the nerves that are affected, there can be associated muscle cramping, spasticity, and pain. There are multiple agents on the market that are used as muscle relaxants. I've put on the slides the names of a few of them: baclofen, tizanidine, cyclobenzaprine, methocarbamol, metaxalone. The mechanism of action of each of these medicines is a little bit different, but they mostly do a very similar thing, which is help relax the muscles and decrease the stiffness and spasticity in them. Common side effects to all of these medicines are drowsiness and dizziness. And across the board, a lot of medications that are used for pain will have drowsiness as a side effect. And this is because they help, if you think about it, they help relax the nervous system a little bit so that pain is not as, it's tolerated better. Last but not least, I want to take a minute to talk about opioids. There's a lot of controversy and stigma with this class of medications. Within the medical community too, there's a lot of confusion about this. And I think this is at least partially related to sudden shift in regulation. Opioids are effective pain medicines. We have found that they are most effective with short-term use, like use after surgery or with an injury or a flare-up of pain. Some neuropathic pain conditions will not respond to opioid medicines. One of the downsides to chronic use of opioids is that it increases the sensitivity to pain. This is called opioid-induced hyperalgesia. And as a chronic pain physician, this is one of the side effects, if you will, of opioids that can be most challenging. So this, with opioid-induced hyperalgesia, with long-term use, things that were previously not painful suddenly become painful, and the baseline pain increases. Other issues related to opioids that you may hear about are tolerance, dependence, and addiction. And I want to take a moment just to clarify what this means, because I think that there's also confusion about them. Tolerance is something that happens to everyone with recurrent or chronic use of opioids. This means that the same dose will no longer be effective. Dependence means that you can withdraw from the medication if you miss a dose or if you stop taking this medicine abruptly. So this will also happen to everybody. This is a physiological event that happens. Finally, the most feared and stigmatized consequence is addiction. And this is use of the medication despite knowing that it harms you, your family, and just things around you. There's a difference between tolerance, dependence, and addiction. And I think we hear a lot about addiction in the media, but a lot of times I think that we confuse tolerance and dependence with addiction. So in the time we have, just to summarize, I want to say that chronic pain can be very challenging to treat. There is no one-size-fits-all treatment. There's a lot of trial and error that goes into treating chronic pain, especially neuropathic pain. Treatment tends to be most successful with multidisciplinary care. And using all of the tools in the toolbox helps pain treatment become much more successful than trying to focus on just one strategy. Thank you.
Thank you, Dr. Jowza. That was really helpful and a very good overview of that information. I'm sure there will be a number of questions for you at the end. So now we will pass the mic over to Sasha Knowlton.
Excellent. I'm just going to share my screen. Nice to meet all of you virtually. Thank you for coming to this webinar series. As was noted in the introduction, I am a physiatrist or a physician who specializes in physical medicine and rehabilitation. And I wanted to talk to you today about how my specialty and providers similar to myself can help in terms of pain management. So I think a good place to start is explaining exactly what a physiatrist is, because I get this question a lot, both in the clinic, at times from other providers. So I think it's a good question to address. And so physiatrists are physicians, so either MDs or DOs, who complete medical school and then go on to subspecialty training that really focuses on individuals with impairments and disabilities. And so really, as I'll explain to you, our specialty is really geared towards helping individuals really manage their pain after an injury or other event. So what exactly does a physiatrist do? So I stole this from one of my academy's websites because I feel like it provides a good overview, really breaking down the different components about what physiatrists do. So first of all, we treat patients of all ages, but really we focus on function, and we also focus on quality of life. And we are able to diagnose and treat pain that can occur as a result of an injury, an illness, or other disabling condition. Our bread and butter, if you will, cases in the past have typically included traumatic brain injury, spinal cord injury, post-stroke care. But as our field has evolved and the overall medical treatment of different conditions has evolved as well, we have started to integrate into other post conditions as well in terms of treatment. which I'll get into in the next slide, I believe. And so our field is really based on comprehensive care. Physiatrists are really the point person or the quarterback, if you will, to lead the comprehensive treatment of pain, but also other functional impairments that may occur. And so while we may be seen as the leader, we're also a team player. And so I work extensively with different therapists, including physical therapists, occupational therapists, speech therapists, and other providers in the community when trying to address pain and other conditions. We also work, of course, with other physicians in the field, whether it's surgeons, neurologists, and even primary care physicians. And what's unique about our field is we really focus on the whole person. Instead of only focusing on a leg or an arm, we really try to provide a holistic and comprehensive management of different functional issues and pain issues that may come up. And so what is cancer rehabilitation? So cancer rehabilitation is really a field that developed in the late 70s and has continued to expand in the setting of improved cancer treatments and early detection. And so the goal of cancer rehabilitation is to improve the quality of life, improve functional independence, also addressing pain, weakness, and other symptoms, and preventing other complications from happening. And as you may be aware, different practices of cancer rehabilitation are popping up around the country, not only in Boston, where I'm located, but also in the Midwest, in the South. And we're slowly growing our tentacles out, if you will, which is a good thing. So common impairments that I see as a physiatrist who specializes in treating cancer survivors are listed here. This is by no means a comprehensive list, but I've tried to highlight on here some issues that individuals who have a history of chordoma may experience. Not only do they experience back pain and nerve pain, but they also can experience weakness, bowel bladder dysfunction, other sensory impairments, and the list goes on. Now, some of these may be directly related to the underlying diagnosis of chordoma, and some may be general wear and tear on the body, completely unrelated, or degenerative changes that result as a life experience, as I like to say. I don't like the word old. So I think it's important as a physiatrist to really differentiate which is which and address them in a stepwise manner, as was previously discussed in the prior presentation. So how can a physiatrist help pain? So first of all, we take a comprehensive history and perform a physical exam. We're sort of the hands-on providers or specialty, if you will, within medicine. Physical exam is really our backbone. We also understand the different components that contribute to pain, whether it's coming from a nerve, a bone, or other cause. Overall, diagnosing the different causes of pain ultimately result in more accurate treatment, which makes sense. We also encourage and refer for appropriate treatments as the therapy disciplines listed below. And we can perform injections, whether of steroid, other nerve blocks, or otherwise, as appropriate to address pain. So it's not a one-stop shop. Each physician, each physiatrist tailors pain management specific to the individual patient. So in chordoma, there's multiple reasons to have pain. The tumor itself can cause pain. Prior surgical interventions, prior radiation interventions can also cause pain. Fractures can also happen, unfortunately, whether it's a bone fracture or whether it's a hardware fracture. Individuals can experience muscle strain as a result of altered biomechanics after surgery or in the setting of recurrence or prior tumor. Spasticity can also occur, which I'll discuss in a later slide. Nerve pain, which is typically described as burning, tingling, pins, needles, and other odd sensations can occur. And skin breakdown can also occur as well, because a number of patients can be insensate or have reduced sensation, depending on where their tumor was and depending on the different types of treatment that individuals underwent. The medications, the treatment, I apologize, the treatment for each of these different causes of pain obviously has different treatments. Some medications are effective for different things. As was discussed in the prior presentation, nerve pain can be addressed by certain pain medications, but it's not necessarily appropriate for pain originating from a fracture or a tumor. A combination of physical and or occupational therapy with an experienced, dedicated therapist can also be effective. Physical therapy and occupational therapy, in my book, is not where one individual goes and works with the therapist for 10 minutes while the therapist rotates around to treat 4 different patients. That's not true physical therapy. A physical therapist is one that works with you for 30 minutes to an hour, one-on-one, which at times can be hard to find, but that's real therapy, and that's how you get the most bang for your buck, so to speak. Compression garments at times can be helpful, particularly for nerve pain. What it does is it helps provide a constant level of stimulation to areas that maybe are hypo or hypersensitive, meaning you have reduced sensation or increased sensation, by trying to normalize the amount of sensation in the area. Bracing can also be helpful too, particularly if an area is unstable and movement causes pain. And depending on the cause of pain, certain interventions such as injections and or surgery may be beneficial as well. So in terms of weakness, I thought it'd be important to include it in the discussion of pain management because a lot of times they go hand in hand. Weakness can occur independently of pain, but it can also occur as a result of pain. Depending on the cause of weakness and where the weakness occurs, it can be addressed with physical therapy, occupational therapy, and potentially speech therapy and vision therapy. Additionally, physiatrists like myself are also experienced in assessing equipment needs, which is not always a fun discussion to have with people. We can assess whether an individual needs an ankle brace or other type of brace, or whether they need an ambulatory aid, such as a cane or a walker, to assist with weakness, but also assist with pain. And while these may not be the most cosmetically acceptable items for an individual patient, I do counsel individuals that, it's at times more beneficial to have to deal with the cosmetic appearance versus falling and breaking a hip or dealing with a traumatic brain bleed as a result of falling. As I mentioned earlier, sensation changes can also occur and can be quite painful during the treatment of chordoma and years after chordoma treatment. Sensation changes have variable symptoms, some of which I've included here. I tend to describe them as either positive symptoms or negative symptoms when counseling patients. Positive symptoms are things that are added on, so pain is a great example of this. Negative symptoms or lack of symptoms include lack of sensation, such as numbness, lack of the ability to tell where your body is in space, which is otherwise known in the medical field as proprioception. That ultimately leads to balance issues, or lack of strength, or in which case weakness occurs. When addressing sensation changes, a physiatrist can help direct care through normalization of sensation, whether it's through overstimulation or desensitization. You can also work on balance and gait training, and as addressed previously, addressing them with nerve pain medications can also be effective. So why care about weakness and sensory changes? Why are we talking about this in a discussion about pain? Because they can lead to bad things, and I don't like bad things to happen, and I'm sure you don't either. When you have reduced sensation and you have weakness, pressure ulcers can result, other wounds can result, and skin can break down. And so interventions that we counsel patients on include learning pressure relief strategies, checking your skin, and establishing effective bowel and bladder programs, which is a completely different discussion for a different day. There's also a risk if you have weakness and sensory changes higher up in the neck or at the base of the skull, where you're at risk for swallowing something to go down the wrong tube. So in other words, you aspirate or get food particles, saliva, etc., into the lungs, which we want to avoid because it can lead to pneumonia and other bad things. Additionally, patients can be at risk for fractures, which we treat at times with therapy, bracing or other equipment, and at times may need intervention, such as a kyphoplasty. So in terms of spasticity, overall, it's defined as increased tone or stiffness that can occur after an injury to the spinal cord. And individuals who have a history of chordoma can be at risk of spasticity, depending on where their tumor was and the impact that the spinal cord endured. And so spasticity at the baseline level of treatment is really treated with stretching exercises on an everyday basis. I tell people exercises like this are like brushing your teeth. We brush our teeth to prevent cavities and gum disease. We stretch to prevent spasticity and pain in much the same way. Additionally, splinting or casting can also be used. Oral medications, some of which were addressed in the last presentation, can also be used. And Botox and/or Dysport injections, which is a relatively new agent to the market, can also be used to address spasticity. So how can you find a physiatrist? As I said, I'm located in Boston, but there are other physiatrists around the country. And so I've put one of my academy's websites up here, along with the website, where you can find a PM&R physician in your area to help you address pain and other issues that you may be enduring as a result of your prior diagnosis of chordoma. So with that, I thank you for inviting me today.
Thank you. Thank you very much. Yeah, that was a lot of helpful information in there, Dr. Knowlton. Thank you. And I appreciate your mentioning the weakness and sensory changes and those things. You know, we'll be doing some upcoming webinars. One will be on fatigue, one is balance and loss of mobility, those kinds of things that often they're not separate issues. They actually kind of interact and intertwine, and one can make the other worse, and those kinds of things. So your message there about the comprehensive kind of looking at everything is appreciated. And as you said, there's a number of things you mentioned that will be different discussions on different days as we continue with these webinars and conference sessions when we're back in person. So thank you. Okay, we will now turn it over to Dr. Peron.
Thank you. I am going to share my screen. So thank you, Shannon, for inviting me. First of all, I'm really happy to be here. And I'm going to talk about complementary techniques for coping with pain. I'm a psychologist at the National Cancer Institute, as Shannon said, and I work with a lot of different pain populations. Sometimes people come to me when they've tried other things like other medications and other techniques and they haven't worked. But mostly I work in conjunction with other members of the multidisciplinary team. And I'll talk about several approaches to pain management, including physical activity, cognitive behavioral therapy, and acceptance and commitment therapy. And then I'll share some resources where people can access some of these things. So obviously with respect to physical activity, you have to take up any new exercise program with consideration of your physical limitations and with the approval of your physician. But a couple of types of exercise that are more gentle are things like yoga and Tai Chi. So yoga involves breath control and body postures and kind of lining up your breathing with various postures and poses. And there is a good amount of research on yoga in terms of its ability to help people with headache pain and back pain and things like that. So it is something that people can do at all different levels, starting out with really gentle poses and moving up in difficulty. Tai Chi is a series of gentle exercises and stretches in flowing motion. It's been called meditation in motion, and it has been shown to be effective for things like arthritis and chronic back pain. It's really fun to do, and in terms of research, I think there's not nearly as much research with Tai Chi as there has been with other types of physical activity like yoga. Cognitive behavioral therapy, or CBT, is one of the most common types of psychological treatments. The goal of CBT is to examine and change maladaptive thought patterns and behaviors. And it includes a wide variety of techniques. So when you go to a CBT therapist, they're likely to recommend things like relaxation, biofeedback, problem solving, identifying and changing irrational thoughts and beliefs, and setting goals to move forward with what you want to do in life. So I'll talk a little bit about a couple of these techniques in particular. Progressive muscle relaxation is a common type of relaxation that is done in CBT. And this is the kind of relaxation where you start out with one part of the body, for example, your right hand, and you just alternate between tensing the muscles in your hand, holding that for a few seconds, and then releasing the tension. And the point is to train your mind to notice the difference between the tension and the relaxation state so that you, in essence, become better at inducing that relaxation state, which can be really helpful when you're in pain. Another type of intervention among CBT therapists is biofeedback, which most of you have probably heard of. It's the process of gaining greater awareness of physiological functions by using electronic instruments. So if you were going to a practitioner who uses biofeedback, you would be hooked up to some sensors and you could see on a monitor how these things are measured. And so you might notice it might show your heart rate over time and respiration and things like that. And the idea is that through practicing relaxation, when you're monitoring these physiological functions, you learn to eventually gain some control over these functions. So you can learn to decrease your heart rate and your respiration to a better state of relaxation. And there is a good amount of data out there showing that practicing biofeedback can lead to reductions in certain types of pain. There are also apps that do kind of a more basic form of biofeedback. And so that's something that you might be interested in exploring. And then I'm getting to acceptance and commitment therapy, or ACT. And this is really the type of treatment that I do most often when patients come to see me. ACT has been found effective with various types of chronic pain, including things like arthritis, neuropathic pain, back pain, fibromyalgia, and others. The thing that's different about ACT from these other types of therapies like CBT is that the goal is not to eliminate a person's pain. A lot of times when people come to me, they say that that's their goal. They want to do this therapy because they want to get rid of their pain or they want to learn to control their pain. From an ACT point of view, the goal again is not to eliminate your pain, it's to optimize your quality of life while you live with your pain. So a couple of the key concepts in ACT are mindfulness and values, and I'm going to just talk briefly about each of those. Mindfulness is defined as non-judgmental, moment-to-moment awareness. And some of the ways that we can practice mindfulness are through things like mindful breathing, which is where we just slow our breathing down, really just notice how it feels as we inhale and exhale, and just focus on the breath over, starting out with maybe a minute and then moving up to 5 or 10 minutes. We also do something called body scans, which is similar to progressive muscle relaxation that I mentioned before, but the goal here is not to change the state of, tension or relaxation. The goal is just to practice noticing and becoming more aware of the sensations that are in existence throughout the body. And then you can also practice mindfulness in daily activities, such as mindful walking, mindful eating. You can listen to music mindfully. You can pretty much apply mindfulness to anything that you do. And there are, a lot of information out there on the internet. If you search for mindful eating, mindful walking, you'll find a lot of resources that walk you through how you would practice this. One of the most common types of a mindfulness-based intervention is called mindfulness-based stress reduction, or MBSR. There's been a lot of research done on MBSR showing that it significantly improves pain and quality of life in individuals with chronic headaches and chronic low back pain and other conditions. It also reduces some of the psychological effects of having a pain condition. On the lower right is a copy of the cover of a workbook that walks you through the MBSR program, which is a really nice resource to have. And then the values piece of ACT is important as well. We talk to people about who are the people in your life that you care about the most? What are the things and activities that are most important to you? And also, how do you want to show up in life? What are the characteristics that you want to embody, even when you're struggling, even when you're in pain or having difficulty coping with your condition? And so the way that we bring these things together is illustrated here. For example, I have a lot of people I work with who might say, well, when my pain gets to a certain level, I tend to just go to bed. I take my pain medicine, I go to bed, I skip dinner, I don't really do anything else. Through mindfulness, we can learn to kind of space out the distance between having the pain and then choosing what to do next. So in that space, it allows us to say, okay, I'm noticing this experience of pain, and I'm thinking that maybe the best thing for me to do would be to go to bed. But also, what are some other options here? Some other options might be to do some yoga, to take a walk, to talk to a friend, to do a body scan, to cook a meal. Basically, all of these other things might be related to your values. They might be things that are important to you. And so by noticing our pain mindfully and keeping in mind our values, we let our values guide our actions rather than letting our actions be controlled by the pain. Some of the resources I wanted to share are some websites for finding a practitioner who engages in some of these techniques. I've listed a few websites that have a lot of good resources for free on them. And a couple of my favorite books that talk about things like mindfulness and ACT. Also, there are a lot of good apps. If you search on the app store for things like relaxation, biofeedback, and mindfulness and ACT. And these are really, most of them have free versions so that you can at least access the basic features of these apps that can help walk you through some of these techniques and processes. And the expectation is not that doing any of these things would get rid of your pain or solve all of your difficulties, but we know that the interventions that I've mentioned here are at least somewhat effective for at least some people some of the time. Thank you.
Thank you so much. I think we got a very nice comprehensive look at many different options that people have. So thank you to all three of you. So as we do this Q&A, if the speakers, if you'd like to turn on your cameras so that participants can see everyone. And we do have some questions that have come in that I will read out and direct to you. Let's see, let's go with this one. Dr. Knowlton, this one's for you. Can you talk a little bit about the differences between a physiatrist and a palliative care specialist, and when patients might seek out input or assistance from either one of those specialists?
Absolutely. Yes, I'm happy to do that because that's also a question that comes up frequently. So palliative care specialists are generally trained as internal medicine physicians, although some PM&R docs also go on to do subspecialty training in palliative care as well, if they're interested. But the focus, and I work with a lot of great palliative care physicians, the focus of theirs is really, yes, it's on pain management. They have different training in terms of physical exam techniques, history taking, etc. And they tend to focus on pain management in terms of medications. And a lot of times will use and dose opiate medications and at times neuropathic pain medications. Physiatrists, on the other hand, really look at things holistically and comprehensively and focus on the functional implications of pain rather than just the pain itself. So it's really coming from two different schools of thought and training. And as I said, you know, there are a few physiatrists around the country that also have gotten subspecialty training in palliative care, which is generally a year after completing, you know, their baseline training, if you will. So excellent question.
So, and it wouldn't be uncommon then, for instance, if someone, if a physiatrist doesn't have palliative care specialization, that a patient might be working with both, that Absolutely. If you have a palliative care specialist working with a physiatrist also makes sense. Absolutely. If it's needed. Yeah. Mm-hmm. Okay. Thank you. We have a question about pain journals or pain logs, and wondering if your patients use those, and if so, are they helpful, and what would make them the most helpful? So maybe Dr. Jowza, we can start with you on that one.
So I have mixed thoughts about pain journals. On the one hand, pain journals can be helpful early on to find a pattern of pain. So when you're working towards a diagnosis, to help clarify the underlying cause. Part of the reason why I say I feel conflicted about it is my goal for the patients is to take their minds off of the pain. So if you're focused on doing pain journaling, then you're focusing on the pain more than you're focusing on doing other activities that you could be doing during the day. So I think early on for diagnostic clarification, it can be helpful, but I think that as we get treatment going and also have established what the underlying cause is, I prefer that patients be more active doing other things rather than focusing on the pain.
Thank you. Okay, let's see. So we have a couple questions about cannabis, but also about any other types of, I guess they would be complementary, like herbs or spices or things like that. Any of those that, just what are your thoughts on those as part of a pain management plan? I saw Dr. Knowlton, you and Dr. Jowza both nodding your heads, so maybe we'll go back to you, Dr. Knowlton. You can start off, and then Dr. Jowza can also speak on that. This is always a big one that people are asking about, and there's laws changing all over the country and access and things. So this is a good one to address.
Absolutely. And so I think it's great that it was brought up because I get this question a lot. And I'll take a step back and say, there's a lot, I would say, in the media, social media and otherwise about the effects of cannabis and its use in pain management. I generally tell patients, especially in my chordoma population, that I like to do things that are evidence-based. Based on research, we know, without a doubt, pretty much that it's effective, doesn't cause any harm, etc. Unfortunately, with cannabis, we don't have that information yet. I know there's a lot of research ongoing, etc. But I would hate for a patient to take a cannabis product or other supplement product and use it and have a not so nice side effect or other complications as well. Supplements are also not regulated by the FDA, and so we don't really know exactly what's going into those bottles that are marketed at pharmaceutical companies and on the internet, etc. So again, it's not like you're taking an Advil or a Tylenol that undergoes strict regulation. You're taking something that a company is making and supposedly has a certain amount of stuff in there, but there's no oversight of that. So I'm always very leery of it. Additionally, in terms of prescribing, I know in the state of Massachusetts, we're actually not allowed to prescribe medical marijuana or even really comment on its use to patients. So that also leads into, it's legal technically at the state level, sort of, but illegal at the federal level. So it gets into a lot of very sticky situations. So that's my 2 cents on it. I'm sure you have more to add.
I agree with everything Dr. Knowlton says, and I get the question about it a lot. And a lot of patients come back with anecdotal evidence that it's so helpful, and then others that come down with anecdotal evidence that it's not that helpful. I think part of the large part of the issue is the lack of evidence. There are research studies ongoing. I think the fact that it's not legal at the federal level makes undergoing some of these studies more challenging. And also for patients who are taking multiple medicines and maybe some of them are scheduled substances, then it becomes legally problematically because your physician's prescribing license comes from the DEA, which is a federal entity. and cannabis is federally not legal, but it is at the state level. So it's a challenging situation for physicians, and it's a conversation that's always ongoing about what takes precedence. But the bigger question of, is it helpful? I think that the jury is still out. It's unclear how helpful it is.
Okay. Thank you both. Let's see. Oh, we get this question kind of often, and this would really be for anyone who might, all three of you who might have had experience with this. Have you had any patients or know of any information about hyperbaric oxygen treatments and neuropathic pain? Or I guess, you know, pain that might be caused from other things like wound healing issues and anything like that. So I don't know, let's see, anybody want to raise your hand if you've heard this or any information on it?
Yeah, so I've had a few patients use hyperbaric oxygen treatment, not specifically for, I would say, chordoma related pain, but more so in the setting of osteonecrosis of the jaw, which can occur more in the head and neck population. And I've seen it somewhat effective there in terms of pain management. I think, you know, other than that, I haven't really seen it used all that much. So.
Is that because it's not effective, or maybe just because it's not widespread of a treatment?
Both.
Okay, got it. So a question that we have also is about being able to, or dealing with the stigma of being on a regimen that includes opioids, and that sometimes they work with a doc, you know, chordoma patients often travel for their main chordoma treatments. They may work with someone at a cancer center, the cancer center where they were treated, and have a pain regimen that might include opioids or even gabapentin in some cases, that is then looked upon as too much, you know, or they're maybe drug seeking when they are trying to work with a primary care or a pain specialist at home who maybe isn't associated with a cancer center. Is there any advice that you can give to patients who might be experiencing this, as far as how to help educate their doctors on what they have and why these really are effective parts of a management plan for them? Dr. Jowza, we can start with you.
So I think that, I mean, that's a great question. And there's I think a lot of patients out there, and not just chordoma patients, who are in a similar predicament. I can't say that I have the greatest advice, but something that I think is helpful is putting the two physicians in touch with each other. I think that a physician-to-physician conversation can go a long way in terms of the course of therapy and sort of the future directions, so that if you're, for example, seeing a cancer specialist or a pain management specialist at a center that specializes in chordoma, and you go home and your primary care doctor is now being tasked with taking over a lot of the treatments that were started, putting your primary care doctor in touch. Even, you know, email is usually very easy with, or not very easy, but easier for physicians, in touch with the other treating doctors, so that they can have a conversation together, so that you don't feel like you're the middleman and you know, pleading for your case. I think that is one technique that can be particularly helpful.
Can I add something to that?
Yes, please.
I was just going to say that I work with a lot of sickle cell patients who end up having to go to the emergency room for their pain and experience what they see as stigma by the physicians and the, you know, medical professionals there, thinking that they are drug seeking and so forth. And one of the things that's helpful for them sometimes is to get support from other patients like them, like other sickle cell patients, or in this case, other chordoma patients who are on similar treatment regimens, and just to kind of get support from each other about how it feels to feel kind of invalidated when people kind of portray that attitude of, you know, this you shouldn't be doing this kind of judgmental attitude. It can be really helpful to just have that support within the community of patients.
Yes, that's a nice point, that you're not feeling like it's happening just to you or that you're alone in it. I think there's so many great questions left and we're running out of time. So I just want to mention that if we don't get to your question, as long as you did not submit it anonymously, we will take note of all these questions, and I or our patient navigator, Andrea, will be in touch with you to try to get you information. A question about physiatry is it necessary to be admitted to the hospital to do a full workup by a physiatrist, or do you work on outpatient basis?
So I mostly am outpatient. So absolutely, most of us are outpatient, really the only inpatient physiatrist. There's some, I would say, more at academic hospitals, more so than community hospitals, that can see someone, you know, while they're admitted to a hospital, or at an inpatient rehab facility. But overall, most of us are outpatient.
Okay, and you gave that resource in your presentation that can help people locate physiatrists in their area. Do you find that physiatrists are fairly widespread, or
they're becoming more
physical
so.
therapy for sure, but yeah,
yeah. So they're becoming more so. I would say we're more widespread on the East Coast, Midwest. The West Coast, there's some, but you know, more of us are migrating that way, which is a good thing.
Okay. I'm trying to kind of put together a number of different questions into one that really have to do with when you're experiencing side effects that are interfering with your daily life from the medications that you may be on for pain, or if you're noticing that it's not working anymore. So Dr. Jowza, you mentioned that you get to a tolerance place where the dosages have to increase, that can often happen. If patients are experiencing those things, what would you suggest as their next steps? Dr. Jowza, we'll start with you.
So just so I'm clear, is the question what happens when tolerance develops to a certain medication, opioid or otherwise?
I think it's more of tolerance, or if there are side effects being experienced that are interfering with someone's daily functioning that, you know, they don't like, or they're concerned about. What should they do next? Are pain specialists open to conversations about those? We should try different things, that they don't just have to keep kind of dealing with that, but there may be things to do to help.
Oh, absolutely. Yes. So I think the best thing to do is talk with your doctor. Some of the options in terms of ways to counteract it or overcome it. Sometimes if you're having a lot of side effects, you can switch to a different medicine, or maybe just decrease the dose of whatever it is that you are taking. Because usually what we see is that you get the therapeutic effect, and then as the dose increases, you can get side effects. And with decreasing the dose, a lot of times the side effects do get less. When a specific medication isn't working, I think that there's no point in taking a medicine that's not working, and it definitely warrants a conversation with your prescriber to talk about other options.
Okay, thank you. Well, I'm sorry to say that I think we'll have to stop there with our Q&A. I do want to mention just a couple brief things before we all go. Please stay connected with us. You can reach a patient navigator for one-on-one assistance if needed. And of course, if there are any questions that have come up during the webinar that were not answered, please go ahead and get in touch with a patient navigator through our website. You can also connect with a peer guide for one-on-one support, or connect with others in our online community. A couple other ways to stay connected with us: the Chordoma Survivorship Survey and the Natural History Study are are two ways that you can contribute both to the work of the foundation as well as research being done to improve treatments for chordoma. And you can do both of those from home, which is really helpful in times like these. And of course, make sure you sign up for our e-newsletters if you're not already, so we can keep in touch. Don't forget to join us for the remaining webinars in the virtual conference series this year. Check our website and keep an eye on our Facebook page for updates on the details of those webinars and the dates they'll be held. And thank you so much to our speakers for joining us today. And of course, thank you all for joining us, participants. We're very glad to have you here. Everyone take care, be well, and we will see you for the next webinar in May.